Hello, everyone. Good afternoon. My name is Alexa Carey, and I'm the Partner Relations Coordinator for both the South and the West RPUs at Care Compass Network. Welcome to today's Lunch and Learn. Today's Lunch and Learn is titled Integrating Trauma-Informed Behavioral Health with Medical Care, Pivoting to Serve Multiple Settings During COVID-19 Pandemic. Before we get started with today's Lunch and Learn, I'd just like to go over a few housekeeping items. Today's presentation will be recorded for quality assurance purposes and may be uploaded to CCN's website or YouTube page. At the end of the presentation, there will be a brief question and answer period. Please feel free to type questions into the chat box that's located at the bottom of your screen. You may send questions at any time during the presentation. I would now like to introduce our presenter, Dr. Barbara Ganzel. Dr. Ganzel is a research neuroscientist, hospice-trained clinical social worker with over 20 years of experience in the study of stress and the impact on the body, brain, and behavior across the lifespan. She is currently the director of Ithaca College Gerontology Institute. Her current work focuses on trauma-informed elder care and the development of behavioral approaches to reducing symptoms of stress and psychological trauma for people at or near the end of life. Everyone, please welcome Dr. Barbara Ganzel.
Hi, folks. I'm Barbara, as Alexa said. I was just talking with Georgia Antwistle, who is here with us today too, with CCN, and she had an experience yesterday that provides an important frame on what I'm going to be talking about. Georgia, could you please share with us?
Sure, I'd be happy to, Barbara. So yesterday I was at a memorial service over at Elizabeth Church Manor here in Binghamton, New York. And they were providing the service for friends and family who lost residents there to the COVID. And it was really a lovely service. They had created a memorial garden with a weeping cherry tree and some other plants and a big rock with a plaque on it with an inspirational quote. And, you know, I think what really hit home with me is the number of residents that were lost during COVID. There were 32 total, and just the impact that it had on the family and friends and on the staff. Just a wonderful group of people over there and everything that people had gone through. So I was just sharing that with Barbara as, you know, a personal example of what has happened in the long-term care facilities, and again, the impact and support that everyone has been giving to each other to kind of weather this time. So thank you for allowing me to share, Barbara.
And thank you for sharing, Georgia. You may notice that the title on this, you know, it's just an important frame on what I'm going to be talking about. You may notice that the title on this slide is a little shorter than the one I put on the formal title of the conversation, because the nature of the project, which was originally the Teen Champion model for trauma-informed long-term care, morphed pretty dramatically during the course of the project because of COVID. And I'm going to be talking about that and how we flexed with it. But let's just get right into it. This is what trauma can do to your care plans. Okay, this is it's an example of you know, if you take the elephant to stand for the trauma in the room, I'll also refer to the trauma in the Zoom. Unresolved trauma can really be disruptive in a lot of ways. People, humans, come with baggage, and some of that baggage can really cause havoc with the care that you want to be giving people, even when you have the best of intentions and they understand that what you're doing is in their best interest. just to give you an idea of the scope of what I'm talking about. This is a study done by the, just a set of data from one study, but there's been a lot of studies in the last 10 years that have been corroborating this kind of evidence, is that this is a study done by the World Health Organization in about 17 countries around the world, just looking at prevalence of exposure to a trauma level event using actually a very conservative definition of psychological trauma. They used 27 target events and one open-ended question, looked at a lot of places, used careful epidemiological methods so that they got a very representative sample in each country, found that over 70% of people across this these 17 countries reported exposure to a trauma level event, with about a third reporting 4 or more. Focusing on the United States, we have more than 80% of the population between the ages of 18 and 99 reporting exposure to a trauma level event in this nationally representative sample. What that suggests is that virtually all of your residents, patients, clients, care consumers are going to have some kind of history of trauma exposure, as will virtually all of your staff. As of November 28th, 2019, the Center for Medicare and Medicaid Services now requires trauma-informed care and long-term care in organizations that accept Medicare and Medicaid funds. And they require a merging of behavioral health care with trauma-informed care since that date. Behavioral health care was required in long-term care that accepts CMS funds in phase 2 of the CMS final rule, and trauma-informed care came in phase 3. Just kind of as a background, there were 3 phases for the long-term, the CMS requirements for participation in long-term care facilities. It was implemented in 3 phases. Again, the second phase required care facilities to include behavioral health care and services for any residents with mental health diagnoses or who display symptoms of mental disorder or psychosocial adjustment difficulties. So a formal diagnosis is not necessary. Requirements to provide behavioral health services to residents with a history of trauma was delayed until this 3rd phase, in part because this is a request for a system-wide culture change. This is a culture change on the order of the integration of person-centered care into long-term care, which was really a landmark event. So the FTAGs that support trauma-informed care in the CMS guidelines include all of these, but sufficient competent staff and to meet behavioral health needs and to provide treatment, behavioral health services and treatment services for mental health and psychosocial concerns came in phase 2. And again, the trauma-informed care became the need for trauma-informed care became effective in phase 3. Whoops, I was supposed to remove that, darn it. This says this says the data for phase 3. I forgot to do the animation, but the upshot is that in the Care Compass Network region, there's few nursing homes have met this requirement, but all will eventually have to do so once things calm down after the COVID-19 pandemic. I just want to point out that my color scheme is not a political statement, and nor is the elephant. Okay, so I just wanted to show you the original goals for the project, which was twofold. The idea was to create champion teams. So there would be 10 licensed behavioral health providers who were going to be trained in an evidence-based trauma-specific intervention adapted for long-term care. And then we were going to train 10 full-time nursing or social work staff within each of 10 facilities to be master trainers in trauma-informed care. This was going to involve 2 full days of train the trainer program, which then they would bring to their long-term care facility. They would team up in this training. Some of that training would be integrated with the training that the licensed behavioral health providers gave. And so then that were associated with the same facility. So then you'd have a licensed behavioral health provider teamed up with basically a trauma champion inside the facility. Then the champion teams together would provide 10 hours of trauma-informed care education to facility staff, develop the trauma-informed standards of care for their facility, adopt person-centered strategies for screening for trauma and for trauma symptom management that CMS is going to require. To help them meet the CMS requirements that behavioral health care and trauma-informed care be integrated in-house. So those were the original goals. I'm going to talk just a little bit first about the behavioral health providers, then I'll talk about what happened with the other part. So just to give you a little more information on behavioral health for the general population for trauma-specific interventions. There are 3 gold standard trauma-specific treatments to reduce symptoms of post-traumatic stress. Trauma-focused, cognitive behavior therapy related trauma-focused interventions. And those are trauma-focused CBT and cognitive processing therapy. There's exposure therapy. And there's eye movement desensitization and reprocessing, which is EMDR. All of these are appropriate if the resident has plenty of time, is healthy, alert, and is competent. So the average behavioral health patient. I want to point out that the US Veterans Administration uses the cognitive processing therapy, exposure therapy, and EMDR. They endorse those 3 as their evidence-based strategies. The World Health Organization endorses trauma-focused CBT and EMDR. They all work in randomized controlled trials. They're all equally effective. Eye movement desensitization and reprocessing works a little faster than the other 2 and has some other advantages. If you're not working with somebody who has a lot of time, is physically not in pain, they're not exhausted, they don't have dementia, they're not delirious, they're alert, they're not in bed, they can come to an office every week for 16 weeks. If they can't do that, if they can do that, you can use any of them. If they can't do that, my suggestion is to use EMDR for the following reasons. It is brief, it's effective, it's evidence-based, just as the, it's effective and evidence-based as the other ones, but it's shorter. It includes 1 session protocols and even 15 to 20-minute session protocols that reduce symptoms. It may not resolve a disorder, but it can be palliative. Clients don't typically have to get worse first, which is more the case with CBT and exposure-related strategies. CBT-based techniques really depend on people doing homework. If you don't do your homework, it is not nearly as effective. EMDR does not require homework, so there's much lower cognitive demand. Exposure therapy requires detailed description of the trauma over and over as a strategy to desensitization. EMDR does not require detailed description of the trauma. There are a lot of formats for the bilateral stimulation that works as a distractor. It's named after moving your eyes. Typically, I've found that eye movements with older adults can make a lot of them dizzy. So we tend to either work with sound in either ear using special earphones, or tapping. Tap shoulders, tap hands, and you can use it with powder puffs that are special to them. You can keep in a little bag, or if their feet are intact and they're in bed, you can tap their feet. If you have, in adapting this for hospice, we've had family members do the tapping on the patient's shoulders, and then they both get treated. It's very flexible and is useful for a wide variety of patients in a wide variety of circumstances, with modified on-the-spot protocols for dementia and people who are nearing the end of life. And then it became March of last year, and we were still trying to train 10 licensed behavioral health providers with 6 full days. We had intended and arranged for and paid for 6 days of in-person behavioral health training with nationally approved trainers in October and November, with 10 hours of clinical consultation with those folks. We had to switch to doing it remotely. The problem was, at that time, the National Certifying Organization did not allow remote training. They pivoted, which allowed us to pivot. So what started out as a how are we going to do this became something we could do. It was awesome. And in fact, we trained 12 of them. We trained 12 licensed behavioral health providers. It was 2 more than originally proposed, but we had some extra money because we weren't going to feed them. And the money we would have used to feed them for that 6 days, we used to include 2 more. These behavioral health providers that were introduced as necessary by CMS in phase 2 of the final rule there's a lot of organizations that are popping up to do this service since that requirement has been created. And these guys are kind of Pony Express riders. They go from facility to facility, and they have a number of facilities that they are responsible to. So we got 2 of those. Because of COVID, things just got very strange. So we reached out to Care Compass Network and got permission to expand to organizations that provide behavioral health services to older adults. So we got 3 hospice social workers, 2 from Hospicare and 1 in Tompkins and Cortland County, 1 at Care First that covers Schuyler, Steuben, and the one in between. Sorry, I'm blanking on that. 3 care management professionals from a care management agency that overlaps with the Care Compass Network region. A couple of medical social workers from the Lord's inpatient and outpatient services, and a couple of physician's assistants from the new Ithaca College physician assistant program who were certified in mental health. All 12 of those have completed their 50 hours of training and clinical consultation. All have been compensated as proposed. And here's some feedback. One of the trainees who took it back to her long-term care facility, this is a him, sorry, said, there's no exclusion criteria for EMDR, the way we teach it. We've been adapting this EMDR to be appropriate to frail older adults, the way you have to adapt an intervention modality to be appropriate to children. Not that older adults are children, but they have special considerations. He said, there's no exclusion criteria. I have an individual who's bedridden. He's lost 50 pounds. He needs palliative care, but he can listen to music. You can use that for bilateral stimulation. It changes the conversation. Another one was working with a patient in their late 70s, early 80s. She too was working. She was working in a continuing care facility. She said, he can be very upset about events in the past, and I can see how his thought processes change and how his affect and his words change to more positive topics. The EMDR seems to disrupt that negative loop and allow more positive memories to emerge. Another person who was actually simply going to audit the EMDR just to see what it was like, she's a long-term care consultant nationally. And she was so enthusiastic, she ended up taking everything and doing everything. And she was licensed to do so it was appropriate. And she said, because of the EMDR training, I feel equipped to help long-term care staff integrate strategies such as things that we teach, present trigger, future positive template, calm, safe place. These practical interventions support the individual residents and give staff a constructive approach to help create a trauma-informed environment by empowering the individual to self-regulate and to self-soothe. And then this is a woman who is working for a continuing care facility. She said, I've always recognized the need for more well-informed behavioral interventions, but I've never felt like that I had evidence-based tools in the toolbox for my population. This training has told me that we're all behavioral health providers and we need to focus on our patients. It's all of our responsibility to use behavioral health interventions when it's appropriate. I've used it multiple times with coworkers and patients throughout this pandemic. It has been career-changing for me. That one made me especially happy. So that is the feedback from our clinical trainees from our behavioral health training. So then we, meanwhile, we're working to recruit 10 full-time nursing or social work staff from facilities just about the time that COVID hit. Long-term care facilities closed. They stopped answering their phones. They stopped answering their emails. Residents started dying and facilities were very, very stressed. As I'd said before, we plan to implement a trauma-informed champion model in each of these facilities, but it was clear that that was no longer going to work. It was also clear that the usual self-care strategies were not enough in this pandemic. Go exercise, go to yoga, go do some personal journaling, be sure to eat right and sleep well and take a vacation when you need to. That was no longer working as good advice. That's just standard self-care advice that you hand to people. And this was especially profound. Not long ago, I was talking with a good colleague. She said her sister was in charge of a makeshift COVID unit in the town south of here. Her sister had been calling her pretty often, sounding pretty distressed, but then the calling stopped. My colleague thought, oh, she's getting on top of it all. But then she got the news that her sister, the nurse in charge of this COVID unit, had killed herself. My colleague said, she was the strongest person I knew. If she can't stand it, who can? We were getting stories, not quite like this, but similarly very difficult, from all over upstate New York. And we asked ourselves, how can we truly be of use to these long-term care facilities in a way that is trauma-informed and that lays the groundwork for future training in trauma-informed care? So we reached out again to Care Compass Network and we said, can we revise our project activities by converting the in-house trauma-informed care champion role to that of a stress first aid champion? Because anybody we talked to who was willing to talk to us, which was very few people, said there was no way that we were going to be able to commit this time to a long-term, to a champion. And there's no way that they're going to be able to do that kind of training and that we're going to be able to revise our policies to meet the CMS final rule. And the CMS tabled the rule for now. So we changed the trauma-informed care champion role to that of a stress first aid champion. And I'll talk about the stress first aid program in a minute. To reduce the requirements for program participation for these champions in their home or organizations. And we added the goal of staff burnout reduction. Okay, so the person that I reached out to was Patricia Watson at the National Center for PTSD. So I teamed up with her and she helped develop the stress first aid model as a self-care and peer support model for the US Navy and Marines. It's been adopted for other kinds of frontline workers, police, firefighters, wildfire fighters out in the woods. And we thought it would be helpful here and now for long-term care in the Southern Tier. So we changed our deliverables to creating 4 stress first aid training tools that were prepared and made available to each organization. This was done in consultation with the organizations that were willing to talk with us, okay? We made we adapted Patricia Watson's stress first aid toolkit to be appropriate for long-term care staff during the COVID-19 pandemic. And we just did another one for healthcare because what's appropriate for hospice and healthcare, or what's appropriate to long-term care, the language sometimes isn't quite appropriate for hospice and hospitals and primary care and care management. So now we have two toolkits. I made a 25-minute video on the operational aspects of stress first aid for long-term care staff during the COVID-19 pandemic. I just did another one for healthcare staff. I was told by the long-term care facilities that 20 minutes was the limit. They were willing to accept a 25-minute video because I couldn't get it down any farther. It took me 30 tries. Anyway, and then we did, with the support from the Finger Lakes Geriatric Education Center, we did an additional 60-minute training module that's available through the University of Rochester Department of Geriatrics in their collaboration website, which I'll show you in a minute, outlining applications for stress first aid for long-term care in more depth, including its relationship to trauma-informed care. And they got animations, and it's done with a professional video group, and it's kind of cool. And CMEs and CEUs are available for that. That's kind of a little extra. And we also made pocket cards of the stress continuum and posters on the stress first aid for each facility. And I'll show you those in a minute. So here's the toolkit for healthcare providers, the one for long-term care. Just the title says that. So if you Google Ithaca College Stress First Aid, you will see the toolkit. So just Google Ithaca College Stress First Aid and you'll get to our Stress First Aid website. In the toolkit, there's more on the stress first aid actions. It's got examples. It's got stress first aid for groups. You can download the stress first aid toolkit. Again, we've got one for healthcare providers. And then here are the posters and pocket cards. These are the pocket cards. These posters use international pandemic street art. Super nurse, and we call this one the winged worker. This is a You Are Essential wall, I think somewhere in California. And then here's a smaller poster just talking about the stress continuum, which we'll see is an important self-check element of stress first aid. We put a snazzy QR code on all of the posters, along with space for people to say when meetings might be. If the tech works right, you can scan this QR code to get access to the IC Stress First Aid webpage. If it doesn't work right, email Ithaca College Gerontology Institute and we'll fix it. My email will be on the last slide. This is the Stress First Aid for Long-Term Care module in the collaboration website associated with University of Rochester Medical School. What we ask people to do is to, with the support of the in-house stress first aid champion and the facility administration, staff would review and understand the 25-minute video on stress first aid for long-term care staff, and at least one person from each facility would watch this more in-depth video, and they'd hand out the pocket cards and make them available and put up the posters. And if they were willing, so they would distribute the pocket cards, deliver copies of the Stress First Aid Toolkit to supervisors, members of administration, and other staff who wanted it. And with the support of facility administration, the Stress First Aid champion, long-term care staff would take pre and post intervention assessments of burnout and perceived stress. We had to make this optional because this was a deal breaker for some of the people, some of the organizations that are joining us. People did not feel like they had the capacity to do this, especially deep in the pandemic during that dying time between like Halloween and Easter. when things just get really hard for frail older adults. So to date, we haven't had anybody get us assessment results. Like I said, our first folks really sturdily declined the assessment, and they made their own knowledge quiz of knowledge gained, which I thought was pretty cool of them. But this is what these assessments look like. This is the perceived stress scale. It's short, it's 10 items. This is an old workhorse of a stress scale. It assesses perceived stress over the last month. It has been used in countless studies of perceived stress in research. It asks you about your feelings and thoughts during the last month. And you just would circle how often you felt or thought in a certain way. How often have you been upset? How often have you felt that you were unable to control important things around you? How often have we felt like that going to our homes and starting working remotely with our children at home, etc. So this is the perceived stress scale. Everybody felt too stressed to do the stress scale. We don't have time to do all of these questions, but you do get the idea. Here's a single item burnout scale. And this is where I'm putting the most of my hopes for people completing something. It is what seems the most true for you in the last week. This is a validated scale that it's been used in national surveys of healthcare workers and specifically physicians. And it's phrased in a kind of a cool way. Overall, based on your definition of burnout, how would you rate your level of burnout? Please circle the answer that seems the most true for you this week. And it's 1, I enjoy my work. I have no symptoms of burnout. You see that they're actually including some definitions of burnout symptoms in the answer. 2, occasionally I'm under stress and I don't always have as much energy as I once did, but I don't feel burned out. 3, I'm definitely burning out and I have 1 or more symptoms of burnout, such as physical and emotional exhaustion. 4, the symptoms of burnout that I'm experiencing won't go away. I think about frustrations at work a lot. 5, I feel completely burned out, wonder if I could go on. I'm at the point where I may need to make some changes or I may need to seek some kind of help. That's the single item burnout scale. I'm gonna ask you if you want to try it, okay? We have a polling question. It is anonymous. I made sure that it was put in as an anonymous question. And so based on your definition of burnout, how would you rate your own level of burnout? This is optional and it is anonymous. Please pick the answer that seems the most accurate for you this week. Okay, that actually shows to everybody, but that's okay. Okay, we will get the burnout, and we've got the answers are about 8% saying I enjoy my work, I have no symptoms of burnout. Occasionally I'm under stress. I am definitely burning out. And the last one, oh no, sorry, there's 2 more. I have symptoms of burnout that I'm thinking about frustrations at work a lot, and I'm completely burned out, and I wonder if I could go on. And that is the burnout scale. So thank you for doing that with us. And that just gives you a sense of where things are in the room, and it gives you a sense of doing that and what it's like to do that, what it might be like to do that as an organization. So I'm going to give you a brief tour through our stress first aid materials. So we're going to just move on. So this is what we talk about for long-term care. And I start out talking about why stress first aid. It was developed for the US Navy and Marines. What do healthcare workers in a pandemic and the US Marines have in common? Both groups are on different sorts of front lines right now, and both have similar, very firm attachments to a culture of stoicism and selflessness, loyalty, morality, and excellence. There are wonderful strengths associated with these guiding ideals, placing the welfare of others above one's own welfare, The vulnerability associated with that is that people tend not to seek help for their own health problems because personal health is not a priority. Commitment to accomplishing mission and protecting others. The loyalty can create the vulnerability of guilt and complicated bereavement after loss. Toughness and ability to endure hardships without complaint. Healthcare workers do not complain a lot, not in the work setting, but it can lead to just not being even aware or acknowledging significant symptoms and significant personal suffering. Following an internal moral compass to choose right over wrong, but that can mean that you feel frustrated and betrayed when others fail to follow or are not allowed to follow that moral code because of health department restrictions in availability of personal protective equipment, all kinds of stuff. Strength is becoming the best and most effective professional possible. But downside of that is feeling ashamed, denying, minimizing imperfections. Anyway, so that's why stress first aid. That's why this is good for the Marines. It's why it's good for police. It's why it's good for firefighters out in the woods fighting wildfires, and it's why it's good for healthcare. This is the stress continuum model. You notice this was what we were giving cards out. We were giving out cards. It's a visual tool for assessing one's stress experience, and it's the foundation of stress first aid, and it gives people a shared language for talking about how they feel. I'm feeling a little orange today. Stress responses lie along a spectrum of severity and type, which is represented here as a shift from ready and green, where people are calm and steady, having fun, mission focused and motivated. People are saying these days, yellow is the new green. It's about stressors that are unpleasant, but they're transient. They do go away. So there's a low risk of stress injury. You may feel grouchy. You may feel a loss of focus. You may have trouble sleeping and muscle tension, and you're not having fun, but it goes away. Stress injury is more severe and persistent distress and impairment that leaves a scar. And how many of us are going to have scars from the pandemic? Okay. Causes we'll talk about. And it features, you're starting to have loss of control, panic, rage, depression. We'll talk about reports of that from our facilities later. No longer feeling like normal self. Unhealed stress injury causing life impairment. This is in the range of a clinical mental health problem. Depression, anxiety, post-traumatic stress disorder, or substance use, which is really a stress disorder by and large. These symptoms persist and worsen over time. People tend not to see them in themselves. They can cause severe distress and occupational impairment. Interestingly, just by itself, using this model adds to your coping skill set. The simple act of naming how you feel increases prefrontal cortex control, reduces amygdala activation, that's my neuroscience hat, but reduces your fight, flight, freeze reactions and helps bring your ability to plan back online. So what we say is, where are you on the stress continuum today? Use those cards every day for yourself and your coworkers. These are the 4 types of stress most likely to result in stress injury. Life threat, feeling as if self or someone you care about is in a life-threatening situation. COVID-19 exposure, illness, or loss. And how much loss have we seen during this pandemic? Grief due to loss of coworkers, family members, friends, and others you care about deeply. Inner conflict, this is moral injury. Moral injury can be more long-lasting. The wounds from moral injury can be more long-lasting than the other 2. Bearing witness to or failing to prevent acts that go against deeply held moral beliefs and your expectations about the world. not being able to practice excellent infection control, doing shortage of PPE, not being able to be with somebody when they're not letting family be with somebody who's dying, even though you know that's what they need at the end of life. And wear and tear, acute or prolonged or repeated stress injury without enough sleep, rest, restoration. Stress injuries are dynamic and they can deepen over time. That makes it important to identify them as soon as you can so that they can be supported and possibility of further injury can be reduced. The earlier a stress injury is mitigated, the better the prognosis. Okay, factors. So maybe you have COVID to the right of you, COVID to the left of you, and maybe COVID in-house if you're a long-term care facility. And we're calling this trauma. There are 5 essential elements of immediate and midterm interventions that relate to better recovery from mass trauma, because that's what this is about. There's 5 core actions in stress. First, there's promoting a sense of safety, promoting a sense of calm. Extended increases in your heart rate, your blood pressure, and respiration are just bad for your body, your decision-making, and your long-term health. Promoting a sense of social connectedness. It's one of the strongest protective and recovery factors when there's serious stress. Promoting a sense of self and collective efficacy. People who believe that they have the tools and training to overcome this adversity are better able to handle stressful events. And promoting a sense of hope. People who have hope and optimism, faith, spirituality, and finding meaning in what they do are more likely to recover from stress injury. And because it was the Navy and the Marine Corps, they renamed it as the 7 C's, okay? Because there's 7 C's for the Navy to roam around on, okay? Cover, calm, connection, competence, and confidence. The 7 C's of stress first aid: check, coordination, cover, calm, connection, competence, and confidence. This is just a brief summary for you guys. Check and coordinate are continuous. You're always checking on yourself and others, and you're coordinating. You always have in mind trusted places to refer people to. And then cover, calm, connect, confidence, and confidence are the core actions. The actual training has examples, animations, quotes from peers. I'm going to skip these pieces for brevity. So for example, just as an example, you're checking in an ongoing way, you're coordinating, getting help, referring as needed. You always know trusted resources. But let's say a coworker is suffering from a gnawing sense of grief following a resident or patient deaths. People this individual knew and cared about. Let's say this person is going back and forth between being unusual, irritable, and unusually withdrawn. You might try the stress first aid actions of calm and connection. Or somebody's increasingly anxious. You might try the stress first aid actions of anxiety, of cover, calm, and competence. In stress first aid, any given stress reaction is handled differently depending on your personality, what's going on in the person's life, and what they're most likely to be able to tolerate. It's for yourself, and this is for others. So this is, again, this is the, I encourage you all to Google Ithaca College Stress First Aid, look at the toolkit. We have that snazzy scan me on our posters. There is also Stress First Aid person-side manner for patient and family support. There's some organizational tools. And we have all kinds of, at the back of the toolkit, we've got all kinds of free or low cost resources for frontline healthcare workers during the COVID-19 pandemic. For supervisors, help for grief, compounded grief, secondary losses, just every kind of grief that's happening due to the pandemic. There's apps for mindfulness, gratitude, meditation. Here's the National Center for PTSD websites. Our data so far. We had our stress first aid champion, Laura Peters at Kendall of Ithaca, was able to take 204 staff members completely through the stress first aid training, and I'm going to show you those results. We don't have anybody else who's completely through it yet. 204 staff completed the stress first aid training. She did 64 people in live classes of 10 or so or fewer. This was showing the video, the short video with a brief discussion. Her quiz was offered between February and March. 140 of the staff did the video and the quiz through the Relias e-learning system. This is what she was seeing with pandemic stress. It's what we were talking about in the orange zone. Tempers flaring, walking off the job, more absenteeism, less willingness to take on per diem work, more staff switching from full-time to part-time, just getting out, some early retirements, and people just leaving for different kinds of work. What she said, which really fits that that earlier slide. I think long-term care is like the military, a suck it up culture. So people hide their pain, their fear, and their stress, but it comes out in other ways. Who received the stress first aid training? This is awesome. Okay, look, they did administration, all of their culinary services. Everybody in the organization was incredibly stressed. Housekeeping, environmental, culinary services, housekeeping, finance, laundry, marketing, reception, social services, rec and wellness, as well as their healthcare services. Everybody was either going to work or they'd been sent home and they were trying to work from home with kids at home. Everybody was stressed. They did 92% of all of their staff. This was really impressive. Housekeeping, for example, they had to go to work. They had, whether or not they had enough PPE, they had to go to work. They had to do extra cleaning, extra days. Nobody had time off in this facility for months and months. They were there, they had to do it all, or they were trying to do it from home in a completely disrupted home environment. And they all needed stress first aid training. Qualitative feedback. Some folks liked the posters and the video. One person said, and this is just from the 64 in the live classes, I felt like a weight lifted off my chest after taking this class. Thank you. Helpful to learn the physical signs of PTSD. It's easier for some people to get because we talked about the physical signs of stress as well as the emotional. Very informative, helpful, good reminder to help others. Somebody really appreciated that Laura was able to take the time to offer this in person. We put closed captions on the video, which is clearly important, and this person noticed it. This person recommended this class to her daughters who work in healthcare, and I hope we can get to them. I also, I hope she passed along the stress first aid toolkit. Some people thought there was perhaps too much content, but they thought it might be helpful. Some folks thought it was dry, and they wanted live teachers rather than the video, but we couldn't be there in person. We would have loved to have been there in person and to train people to do this. They wanted videos of real life experiences and more examples, and we've got that in the new toolkit for healthcare workers. After video, they wanted to talk about what it's been like for them this past year. And then somebody said, teach us how to deal with the negative, non-receptive people who need the help you're trying to offer. And I thought, oh yeah, but those are the people who need it most, and just being aware and giving it a try has value. Laura shared some people who gave the course a rating of 10. Overnight maintenance staff, a vulnerable environmental services worker who resists education, a number of night shift certified nursing assistants. These people were, people tend to die at night, and these folks were there. A maintenance worker who's also an EMT or firefighter. Dining staff member who was a child of a parent with special needs, is a mom of a kid with special needs. I hear it. And trauma survivors in general. In all, we, as I said, we've delivered the adapted EMDR trauma-informed care training because we added a trauma-informed care component. I'm that instructor. Had stress first aid training completed for 204 people. We have several more organizations in process, including Hospicare, Schuyler Hospital, and in particular Seneca View says that they want to do it. People from the entire Cayuga medical systems are saying that they are interested, and then folks at the Lord's Hospital the social workers in primary care, and also folks in the COVID unit. The trauma-informed, we have a trauma-informed care video library in process for when these people need to integrate trauma-informed care into the long-term care eventually, okay? So we are delivering 6, actually more than 6, 30 to 60-minute training videos on trauma-informed care in long-term care. These are developed in assistance with expert long-term care consultant. One on psychological trauma in the context of aging, trauma-informed care in the long-term care organization, trauma-informed care planning. These are things that there are very few resources out there nationally. I am the first author on the first chapter on trauma-informed care, long-term care for a textbook on long-term care, using what you're already doing to guide trauma-informed care, trauma-specific precautions for long-term care residents, and how to do trauma care, trauma screening when your people may not be average behavioral health patients who you can hand a pencil and paper test to. We're using the money for travel and food during training to pay a video company to make these a little nicer. Okay, I am going to do a quick check, and what I'd like to do is, this is a time check, and does anybody have questions? Georgia, Alexa, is there, how are we doing? We've got about, I've got us having about 7 minutes.
I have not received any questions in the chat box to my a direct message or in the chat box itself. If anyone does have questions, please feel free to insert them in the chat box.
Okay. Did you have any questions that you came up with yourself? Just wondering. Oh, we got it in the chat box. Okay. That is fine because I've got more content. Anyway, because yes, anyway, so this is something that I would like you folks to consider. I'm not going to have you guys do it because it involves reading a lot of questions, but I want you guys to consider the life experiences survey, which is something that I do in larger groups. This group is smaller, and people may not feel comfortable about whether or not they're anonymous. But this is a life experiences survey that I do in a lot of groups. It gives people an idea of the trauma in, if I'm doing it in person, it gives an idea of the trauma in the room with them. Other providers, administrators, frontline folks who are actually providing either care or developing services. This is a standardized survey. Have you experienced a natural disaster? The way it goes is, have you experienced a natural disaster? Well, the answer these days is yes. COVID-19 pandemic counts. A human-made disaster, that's a matter of opinion. You could say yes or no. Serious accident or injury, chemical radiation exposure, life-threatening illness, death of a spouse or child, kidnapped, taken, this actually translates to death of a loved one. Kidnapped, taken hostage, terrorist attack or torture. Have you experienced it or not? Combat, have you been in combat, war, a war zone? Have you had to handle dead bodies? Responsible, have you felt responsible for serious injury or death? Have you experienced attack with a weapon, physical abuse, child abuse, physical abuse as an adult? Physical abuse or witnessing abuse, sexual abuse as a child, sexual abuse as an adult, or another bad thing. If you add them up, this is your LES score. We were going to maybe do it. The results would have been here. But what I want to say is, to close, that there's lots of kinds of trauma. Oh, I should point out that in general, for a group of caregivers, last one I talked to was about 400 care providers. They were spiritual care providers, actually. People run around in here. I did this, a similar talk, or I did this survey with about 35 administration in a large continuing care facility. They ran around in here on average, okay? The point being that there's lots of kind of trauma. They all matter. And whenever we talk about trauma, there's a chance that what is said will touch your story in a way that brings up difficult feelings and memories. And that is normal. Most of us will experience multiple psychological traumas by the time we're 60. The average is more than 6 in lifetime, because you accumulate them as you live. More chances to get hit by lightning, more chances to be in a random car accident. Most of us will have a loved one who experiences trauma. Please do what you need to take care of yourself. We're all in this together, and we need to take care of ourselves as well as one another. I'm talking to the Cayuga Health Systems people. What they said was, we try to use the airplane analogy. You have to put your mask on before you help other people. So take care of yourself. If you want to get in touch about anything, I can be reached at bganzel at ithaca.edu until June 30th. That is when, due to pandemic-related budget cuts, the Gerontology Institute will cease to exist as we know it and become 2 part-time faculty and 1 soft money person. After that, I'll be available at blg4@cornell.edu. Please don't contact me at this before that, because I don't check that as often as I should, but I'll start checking it after June 30th. Thank you very much.
Thank you so much, Barbara. We really appreciate you joining us today. There's one question and a few comments. So the first question is, will you be able to go back to the original project?
No, well, not unless somebody gives me money. I would love to go back to the original project, but I'm going to have a full-time job. I have taken a job as a therapist. I may be able to, it's not clear. I may be able to do it part-time and do some of this work as well. But somebody would have to give me money. I would love to be able to do that, because it was a cool idea, but somebody else can take the model and run with it. I will help, I will advise, I will provide free consulting. It needs to be done, because people in long-term care are just thrashing around all over. I mean, they were thrashing around trying to integrate trauma-informed care into long-term care before the pandemic. Now CMS has just taken all those rules off the table. They're only trying to enforce things to keep people alive and safe. But they're going to go back to it sooner or later. And then they're going to have to do the trauma-informed care stuff. So if folks want to try it, you know, there's a need for trauma champions inside facilities that can help get this going. Care Compass Network, it was a great grant. It wasn't a big one. You know, it doesn't take that much money to do that work. But we were able to hire a fabulous consultant from actually Arizona. And she's helping produce the videos instead. But there is need for that training. And I could maybe do it, but again, there's not the money.
There's a comment from Sally. I'll share while you're still on, but she says, thank you, Barbara and Ithaca College, for bringing this training to those on the front line. You made a difference. On behalf of CCN as the North Regional Lead, I appreciate all that you do for those in the region. I'll stay in touch.
Okay. And
I
thank
have
you.
your number. I have
Okay.
your number, Barbara.
Okay. And thank you for giving us this opportunity. I ran into Stress First Aid because I was, you know, all those webinars that you sign up for, but you go to half of them. One of them was by Patricia Watson on Stress First Aid. And it was at the beginning of the pandemic. I was going, what do I do with this grant? I can't do what I said I was going to do. I reached out to her and she just showed up. She lives in Hawaii. She gave me the resources I needed, and we've been collaborating ever since. She's rolling out Stress First Aid to a lot of places on the East Coast. And that's been really interesting. But what I am doing, in case, you know, the trauma-informed, the EMDR for frail older adults, that's what I want to keep doing. And so
that's good to know. That's good to know. There's not a lot of EMDR therapists available. I adopted an almost 10-year-old daughter, and so EMDR was our go-to for
Yeah.
her reactive attachment that most at that
Yeah.
age have. But yeah, so that's good to know. Again, another reason to keep your number, and fellow
Well,
special needs parent too. So
I've run 3 trainings in town. The first one was general, and we trained about 20 plus healthcare providers, a small subset of which were hospice and palliative care providers, and the rest were local clinicians. Those are kind of the embedded local clinicians now who do EMDR, because a bunch of the rest have aged out. I hope what I'm working now is to get credentials to be a trainer myself, because we've had to bring in trainers from Kansas and California. And our local, we have one local trainer, but he's aging out of it too. So I hope to be able to provide some of those services, because it's needed. Okay.
Thank you so much, Barbara. We really appreciate it. Everyone who's still on the call, thank you so much for joining today's Lunch and Learn. We will see you next month for another Lunch and Learn. Have a great weekend and enjoy the sunshine, everyone.